You're listening to Medscape's In Discussion series on psoriasis, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Steven Feldman, Professor of Dermatology, Pathology, and Social Sciences and Health Policy at Wake Forest School of Medicine in Winston-Salem, North Carolina. Relevant disclosures can be found with the episode show notes on medscape.com. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hi, welcome to Medscape In Discussion on Psoriasis. I'm your host, Dr. Steve Feldman. When psoriasis is extensive, it can have an enormous impact on patients' lives. We have many treatments now, including biologics. Before we had such revolutionary treatments, we relied on older drugs like methotrexate, cyclosporin, and phototherapy. Does phototherapy still have a place in psoriasis treatment? It's far less costly than our biologics. To discuss the role of phototherapy in psoriasis, our guest today is among the most accomplished scientists in dermatology, perhaps the most accomplished scientist studying practical issues in dermatology. He's Vice Chair of Clinical Research and Medical Director of the Dermatology Clinical Studies Unit at the University of Pennsylvania, which is perhaps the leading center for clinical dermatology care and research in the United States. He's also Professor of Dermatology and of Epidemiology and Biostatistics and Epidemiology. Our guest also runs UPenn's Psoriasis and Phototherapy Treatment Center. I'm excited that we get to talk with Dr. Joel Gelfand.
Thanks for having me here. Thank you for that kind introduction and for triggering my rosacea. I think you made me blush a little along the way there. So,
Joel, listen, you've had such a remarkable career in dermatology, and you're not even old yet, like some of us. You're doing, I think, what's arguably the most important and cutting-edge research in our field. I remember, I don't know how I came across it, but I remember reading an article of yours that was on adherence to anticoagulants. What took you from there to where you are today?
That's a great question. I was a person, one of those people who always wanted to be a doctor. And in college, I got interested in public health because I felt that got me closer to health issues and patient issues, which is about as close as you get as a college student. And then in medical school, I was at Harvard, and I was interested in clinical epidemiology as a way of doing better research and understanding patient experience. And I was working with a guy named Danny Singer, who's won a lot of teaching awards. He's an epidemiologist at Harvard and a physician as well. And he was studying and doing the initial Coumadin trials to prevent stroke in patients. And compliance or adherence with Coumadin was a really important issue. And so I got interested in that topic and got to work with him for a summer. And that was one of my early publications as a medical student at that point in time. But eventually, I thought I was going to have a career in general medicine, took an elective in dermatology, thinking I needed to know some dermatology. And a guy named Dick Johnson, who was then at the Beth Israel Deaconess Hospital. Many people may know him. He wrote the Clinical Atlas of Dermatology. So a lot of us learn the images of derm by his photographs. And couldn't help but fall in love with dermatology. First day on the rotations really impressed me. The variety of diseases we see and the incredible impact we could have on patients' well-being in their lives. And then incredibly at the time, HIV was a big issue. This was in the mid-1990s. And I was really interested in HIV disease as well. And when I got interested in dermatology, there was a big controversy in those days about when that ultraviolet light would be safe for people with HIV. And in those days, and still today, we use it for like eosinophilic pustular folliculitis, for prurigo nodularis, for psoriasis, a whole host of diseases that people with HIV are more prone to. But in those days, there was a sign from basic science models, mouse models, that ultraviolet light could activate the promoter of the HIV virus. And the worry was that if you hit people with ultraviolet light, you could rapidly progress your HIV disease, cause further immunosuppression, and have bad outcomes. So I took a year off of medical school to try and better understand my interest in dermatology, get some more experience in research. I met a guy named Mark Lebwall, who was at the time the only person who said, if you come up with a clinical idea, a clinical study you want to do, and you could design it and figure out how to do it and fund it, go ahead, you can do it. But in the meantime, you'll be in the lab like most medical students were. And sure enough, I came across a woman named Mary Klotman, who was head of ID at that time. And we designed a study where we followed a cohort of people with HIV disease getting phototherapy at Mount Sinai. We followed their HIV viral levels by PCR at a repeated time point during the course of their treatment over several months. and basically showed that their HIV viral levels didn't change at all. They were rock steady the entire time. And that was one of my first main publications in the field of dermatology back in the late 90s. And to this day, that's still like the main paper we rely on for the safety of phototherapy in people with HIV disease, where we still use phototherapy pretty commonly in that population.
Very cool. The medicine's such a small world. I remember when Dr. Klotman, when I was a medical student at Duke, I think she was a medical resident.
That's right. That's exactly right. Yes, and she's back now at Duke as the dean.
The head of the place. Yeah.
That's right. Exactly.
It's such a small world. I'm old enough to have started to take care of psoriasis patients before we had drugs that just bam clears it up. So we relied heavily on phototherapy. Today, what makes somebody a good candidate for phototherapy?
Well, taking a step back, it's true. We've made a lot of advances in the field of dermatology, psoriasis in particular. And it's such a pleasure to be able to help take care of these patients, because having people who struggle with their disease for so long, and then in some cases, within 2 to 4 weeks, are completely clear, is just like an amazing clinical experience for the patient, and always incredibly gratifying for us as clinicians. But that being said, none of our therapies are perfect. Patients often lose response to treatment over time. Having the availability of phototherapy to help bridge patients when they're not potentially doing well on a biologic, or for a fairly substantial number of patients who really are just concerned about using systemic agents for their disease. A lot of people are looking for what they would consider to be a natural or alternative way to manage their psoriasis. And this is obviously something that's very patient-centered, very popular with patients, because they feel like this is something they could do to manage their disease without having to use pharmaceutical interventions. And, it's pretty remarkable. The efficacy of phototherapy is quite high when it comes down to it. We did one clinical trial where we compared it to adalimumab, one of our TNF inhibitors, to look at its cardiovascular effects. And interestingly, the first thing we saw is actually phototherapy had some important benefits in the cardiovascular realm. It lowered C-reactive protein and lowered IL-6, which are both important biomarkers, inflammatory biomarkers for cardiovascular disease. Did that compared to placebo? It also improved HDLP, the so-called good cholesterol. And of all the drugs we studied, only phototherapy had that benefit. And so it's interesting. There's not a ton of research out there about what ultraviolet light does to the cardiovascular system, but the little bit that's been done generally suggests it has a favorable outcome. And I think there's more work that needs to be done there. But coming back to efficacy, what really surprised us, because this wasn't the point of the study, it was just sort of secondary things we looked at, the PASI 75s were the same for phototherapy compared to adalimumab. And this was a trial targeting people who want to be on biologics. Ultimately, they all got open label adalimumab, so a lot of them had bad scalp disease, bad nail disease, adrenal disease, not the kind of people you may treat with phototherapy. And the other thing is the PROs, the patient-reported outcomes. So in general, both groups did very well on the patient-reported outcomes, but in general, the phototherapy people tended to do better than the adalimumab people, including on the EQ-5D, a measure of overall health and wellness, particularly when it came to pain. People getting ultraviolet light had a statistically significant improvement in their overall feeling of pain compared to placebo. That was better than what was seen in people getting adalimumab. This is a kind of striking finding. And I think it comes back to some of your own work, Steve, years ago, that demonstrates, phototherapy does have some sort of salutary effects on people, right? People feel well on it. It increases endorphins and whatnot. The other thing we can't disentangle, of course, is the impact of our staff. What does it mean to a patient with a chronic, stigmatizing, isolating disease to come to a place on a regular basis and interact with people who understand what's going on, who are empathetic and supportive to them? That may also have a major benefit of what's going on from what we observed. So as a therapist still has a lot to offer for patients. And in my own practice, I'm pretty practical with people. I basically lay out what their options are. I say, we're lucky. We have a lot of good choices for you. Let's discuss what your options are. And, generally, I'm going to try and avoid letting a patient choose something that's definitely not in their right interest. So, maybe someone's had a lot of skin cancers in the past and has some signs of psoriatic arthritis and maybe a lot of nail disease or scalp disease or genital disease. Well, I'm going to try and shift them away from trying phototherapy. But these modalities are still very valuable in our armamentarium.
I get the sense that the dogma is that if you have a patient with psoriasis and arthritis, the phototherapy could help the skin, but won't help the joints. But I hear you saying that it lowers CRP, it's lowering systemic levels of cytokines.
Yeah.
Might it improve the psoriatic arthritis too?
We don't know. So certainly at this stage, we'd have to consider it to be something that would be, not our main understanding of the effects of phototherapy. It could be studied possibly. But even in that setting, people with psoriatic arthritis, occasionally they're doing well on their biologics or their other DMARDs that the rheumatologist has them on. And then phototherapy is a good option if they're not doing that well. They finally got their joints under control, but they may still have residual skin disease. And then ultraviolet light may be something that could be really beneficial to help them get full control of their disease without having to worry about, changing their regimen and losing response in their joints. So it's another situation where one might want to consider phototherapy. The other thing is people who are extremely medically complex. I just saw a patient the other day who has lupus. She's on a whole host of immunosuppressants. She has some localized stubborn lesions of psoriasis. I offered her external laser. That is not going to trigger her lupus for, focal use of UVB. I'm not giving her to her entire body, but she did not want to go on biologics and yet additional immunosuppression to the already immunosuppressive medicines she's on. So these are modalities that for those of us who treat complicated patients, or even not necessarily complicated patients, it's being centered around what the patient's preferences are. It's something that is really important to have in our armamentarium to offer people.
What are the various options for phototherapy? What kinds of phototherapy do we have, and how do we decide which to use?
Yeah, so we certainly have a variety of modalities in my program. We offer, narrowband phototherapy, sort of total body, a unit that surrounds the patient. We have hand-foot phototherapy, which in our shop, we use mainly UVA. So we're adding Sorlin to that. So patients with difficult palmoplantar pustulosis, we treat a lot of those patients. I mean, let's face it, as much progress we've made with biologics, it's sort of trial and error trying to help people with palmoplantar pustulosis. But they do pretty well with topical PUVA. So that's an option we use for those patients a lot. There's external laser, so concentrated UV light to individual lesions can be very helpful. And, sometimes patients get, real long remissions, particularly with external laser. And so another reason why I use phototherapy in some patients is that for people who are worried about being on long-term therapy or feel like they don't want to have to take a treatment for the rest of their life, you could try phototherapy, and occasionally have people take a home run, like they go into remission, they're fine for a couple of years. Now that's not the typical experience, but it does happen. And that's another reason to give these things a try. The other option, or really the biggest challenge of getting phototherapy, is being able to get people into the office. And so home phototherapy is certainly an option. There are multiple vendors who make these devices. They come in different shapes and sizes, things that are 4 feet high that just treat part of the body. I personally don't like to use those. Those seem to be pretty hard to use in my mind. I tend to use something that's sort of like the size of a door, exam room door, so they could treat the entire one side of the body, and they could turn around and get a dose on the other side of the body. And the last thing I would add is that, Penn is one of the few centers that still does Geckerman, where daycare, we call it. Patients will come in, they'll spend a couple hours in tar, they'll get a little dose of UV light, they'll get maybe some amphotericin cream. And that's a therapy that can be pretty helpful for people who are, running out of biologic options, may have unusual contraindications of biologics or other reasons that they can't go on them. And, it's a pretty remarkably effective therapy. I mean, you got people come in who have just, very severe psoriasis, PASIs in the 30s or 40s, and in 3 days, they can be close to clear. I mean, it's almost nothing works as fast as good old Geckerman. It's just that these days, logistically, it's so hard to do, and it's rather unpleasant for a lot of patients. So it's certainly not very popular now.
My enthusiasm for offering patient tar as a treatment went up after many years of disuse when we learned that aryl hydrocarbon receptors were mediating how it worked.
Yeah, it's fascinating. And also, maybe we know they tend to get remissions. And so it'll be interesting to see with the new topicals targeting that mechanism, whether or not they're more likely to get remittive effects from it, whether or not they have more remittive effects with phototherapy. We have a lot to learn with these new MOAs coming to use for topicals and psoriasis, which is really exciting.
I don't think you mentioned sun exposure. Do you consider that a form of phototherapy?
I certainly do. And, for many of my patients, the strategy may be, all right, we're going to treat you intermittently. And even some of my patients who really just don't want to be on pharmaceutical medications, they may be on biologics over the winter when things are bad. but then when the sun's coming out, they could often keep themselves in remission with this natural sunlight. And so usually what I'll tell people is that they want to go out, as close to noon as possible, because that's when you have the most UVB coming out of the sun in terms of what's going to hit the skin. And you try to give it an estimate based on their skin type. So they're very fair skinned. They may want to start with 5 to 10 minutes max. They're very dark skinned. They might be able to do half an hour to an hour without much concern. I'll often tell them to say, put a little baby oil on the psoriasis itself, because what you want to do is improve the optical properties of the skin so the UV can penetrate better. And most patients will know this. They'll already tell you, like, well, in the summer, doc, it clears up. So it's certainly a useful thing to use for the appropriate patient. And of course, I usually try to encourage people to say, well, areas that are not involved, like your face, cover that area up. You don't want to accumulate too much photo damage or sun damage. It's going to be a problem for you in the longer term.
Dermatologists tend not to like tanning beds. I believe tanning beds are the most widely used form of phototherapy by people who have psoriasis. Is that something you ever encourage a patient to do?
This is a really great question, Steve. And I tell you, I think it'd be a great thing to test, because I think you're probably right, actually. I'm involved in a number of social media platforms, including one called COPA, and patients talk about tanning beds a lot and find them helpful. It's ironic, as a person who's sort of, an academician and tries to do things by the book and tries to follow the science, we sort of think, well, tanning beds these days are mainly UVA, right? They don't have that much UVB in it, because the goal of tanning beds is to tan people and not burn them. And of course, UVA gives you immediate pigment darkening. So that's really gratifying for someone using a tanning bed. They come out and a few hours later, your skin looks a little bit tanner, because of that UVA effect, right? So, in theory, it shouldn't be that beneficial, but certainly patients tell us all the time that they find it helpful. So, I generally don't recommend it, but if my patients want to do it or they think it's helpful for them, I don't say no. I just encourage them to explain to them what the potential issues are.
I practice in a relatively rural area. People are very spread out. It's cumbersome for people to drive the distance they have to drive to come for phototherapy in my office. In contrast, you work in a high density area where people are much closer. On the other hand, traffic is much worse too. I know a dermatologist who's got a light box in his office. He has psoriasis. He has a home light unit. He does his own light therapy at home. What are some of the advantages and disadvantages of home light?
Well, this is a great part of the discussion, because I think, as physicians, we often forget how much we're asking people to do, whether it be the complicated topical regimens we're asking them to do or what have you. And, for one of my patients who for years wanted to do phototherapy, and he would do well on, he usually clear, but would come back. I was trying to convince him that he should go on a biologic instead, because I felt like at this stage, he just wasn't having as good a response as he could have. But he was just uncomfortable with that approach. And, I calculated out the amount of hours he had spent coming to and from phototherapy, even though we're a high population density area. Someone may be walking 4 or 5 blocks away, but that's still at least anywhere from a half an hour to an hour out of your life by the time you get from point A to point B. The treatment, just a few minutes, very quick. But the time they go from A to B, it can set people back. So in any event, I think certainly when you survey patients, treatment at home is highly popular, highly preferred for many reasons. It also avoids a lot of the discomfort patients may feel about disrobing, in a public place. They have privacy, the doors are closed, et cetera. It just often feels uncomfortable to people, right? They'd rather do it in their own home. And, we're doing this thing called the light study right now, the light treatment effectiveness study, which you're a part of. And when I offered this study to patients where we explain, well, it's just in routine care. And if you're willing to do phototherapy at home, we'll flip a coin and send you a machine if it comes up one way, or you just do it in the office like regular if it comes up the other way. Their eyes often get really big and excited, because if you think about it, like the power of being able to decide when you're getting your treatment done, right? So to not be focusing the whole day like, oh no, I need to get to the doctor's office by 2:00 on Monday, to know like, all right, well, I can't do it 6 p.m., do it 7 p.m. I'll get to it when I could get into my day, or do it on a weekend, or if I'm traveling and things of that nature. It really gives patients an enormous sense of control over their own disease management. That's really empowering for them. And, to me, it's one of the gratifying parts of research is just to see how happy patients are when they're doing well with it, because then they feel like they have more control of their disease.
When they're on home phototherapy, can you manage them using teledermatology services?
Well, the pandemic, if there's been a silver lining, it's been the rapid adaptation of telemedicine, teledermatology, right? So, March 2020, I was doing approximately 0% teledermatology. And then April 2020, I was doing 100% teledermatology suddenly. So I do manage a lot of patients with telederm on phototherapy just to do the counseling, the initial assessment, whether they're appropriate. But certainly we do want to see these people in person, at least probably once a year, do a thorough skin examination, a skin check. So, I think telemedicine is very helpful for counseling, managing well-controlled chronic conditions, maybe looking at a couple of things. But for doing a good detailed skin check, it's more challenging, I think.
While I've got you here, you're the leading epidemiologist in the world of dermatology I know of. You mentioned that phototherapy seemed like it was having a positive benefit on cardiovascular markers. You think it's possible that the net effect of dermatologists telling people to stay out of the sun, which has its benefits of reducing skin cancer risk, is actually overall a negative risk, having a negative effect on mortality? Because if you're having even a small positive effect with sun exposure on cardiovascular risk, potentially could swamp all the mortality benefit of skin cancer reduction.
That's absolutely right. So for example, we just think about psoriasis as a model. The excess risk of a person with psoriasis having a cardiovascular event that we think is above and beyond a traditional cardiovascular risk factor far outweighs their risk of ever having melanoma. Like it's by logarithms. I don't think we know the answer of it. And there is some studies showing epidemiologically people who get more sun exposure tend to have lower rates of cardiovascular disease. It's really hard to tease out cause and effect because, getting good sun exposure may be related to other behaviors that allow you to be in good health, whether or not you have the economic wherewithal, for example, to do these things. There's some experimental studies in the dermatology literature that ultraviolet light lowers blood pressure through nitric oxide, increasing nitric oxide. So there's a mechanistic component to that there. And I think the reason why we haven't sorted this out is the reason that a lot of things in medicine don't get sorted out, that you don't have the right brains coming together, right? Like the people who know about cardiovascular disease know nothing about photobiology, right? And the people who know about photobiology don't know anything about cardiovascular disease. So it's very hard to bring these two disciplines together. Ripe area for research, in my opinion.
What's one thing you want to pass on to listeners before we wrap up?
Yeah, I think that with all the progress we're making in the field of psoriasis and having more options, the more options we have, the more options we're going to need, because more and more patients are coming for treatment. That means more and more patients will do well, but will lose response or will have preferences for different things. So to really be able to completely manage this disease, you have to have phototherapy available to your armamentarium. You want to be able to offer both narrowband phototherapy, excimer laser, topical PUVA, because invariably you're going to have patients who are going to come in who will need those type of treatment options. And it's a great way to help our patients.
Yeah, and with the availability of home phototherapy, I think in theory, even if you didn't have the office as phototherapy as an option, physicians can be offering people ways of getting home.
Yeah, absolutely. And I think one of the goals of the Light Study is really to understand, it's a study of about 1,050 people. Ultimately, we've already enrolled more than 600. And we hypothesize that home treatment will be just as effective as office treatment. And really the challenge patients and providers have is that it's very hard to get insurance approval for a home machine. Oftentimes, insurance companies are aligned by durable medical goods. And so you prescribe a machine that may cost $4,000 and they'll say, wait a second, I want this on my budget. Have the pharmaceutical side spend $80,000 a year for life for this patient, whatever that biologic is going to cost, because that helps the bottom line of durable medical goods. And so, our Medicare patients, actually home phototherapy is actually covered. It is covered by Medicare. And certainly a lot of systems like the Kaisers and the ones that are, where the insurers also delivering the care often make phototherapy available to patients. And hopefully the work we're doing now will improve that access as well.
Joel, thank you so much for taking time out of your extraordinarily busy and productive schedule to talk to me today. For our listeners, be sure to look for our next episode where Dr. Bruce Strober will talk with me about oral agents for psoriasis. I'm Dr. Steven Feldman, and this has been Medscape in Discussion on Psoriasis. See you soon.
Thanks for listening to Medscape's In Discussion Psoriasis podcast series with our host, Dr. Steven Feldman. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out medscape.com for show notes, links, and more information on psoriasis.